thank you all for coming on this kind of ominous looking Saturday and for sticking it out to the last talk. First thing, I'd just like to address the elephant in the room. This is what my face looks like. For those of you who don't know, I've had a beard for much of the last 7 or 8 years. So this is the first time I've been really cleanly shaven. My own kids did not recognize me. So our talk for today is symptom management, specifically spasticity. So what you've heard so far from the other speakers have been about immunotherapies, things that we can do to try to manipulate the course of the disease so as to prevent the long-term accumulation of disability, so as to prevent relapses, all of which is, very important. But, we're switching gears now because we want to talk about how to manage the symptoms, the bothersome symptoms that some people have, on a day-to-day basis, which, I think is extremely important. So let's see. Do I click with the mouse or do I use the key? Oh, okay, here. Yeah, no relevant disclosures for me today. Well, at least in terms of potential conflicts of interest, although I suppose I should disclose that some of the images you will see are AI generated using DALL-E 2 because I think it's kind of cool. And there's a little, I think, kind of like a rainbow icon in the lower corner. But the rest of the talk is human generated, meaning by me. So what is spasticity? Spasticity is defined as a velocity-dependent abnormal increase in muscle tone or muscle contraction. So how does a person experience that? Well, sometimes people will tell me that they feel their muscles tighten, or that they feel like wood, or like cement. It can be like a temporary but severe cramping kind of sensation, or it can be a more prolonged just increase in tone. In severe cases, we can see the spasms or spasticity leading to things like contractures where there is limited range of motion and a limb is kind of locked into a certain position. So when we do neurological examination, we can kind of start to tease out what's going on here. So for instance, when we check your muscles, we're not just checking for how strong you are, which is important too, but also kind of how good is that range of motion? Is there resistance to passive movement, and what is the pattern of that resistance? We'll notice spasticity from MS and from actually from a variety of different conditions, but the topic of today's talk is from MS, tends to have a kind of a particular pattern, involves certain muscle groups more than others. So for instance, things like head and neck muscles tend not to be as much, tends to be more in the limbs and sometimes in the midsection. You tend to see in the upper extremity kind of more of like this kind of thing where the biceps are flexed, the wrist can be flexed, and kind of your arm is kind of drawn into the body, as opposed to something like where your arm is kind of out here like that. We don't usually see that kind of thing. So it's like particular muscles that tend to be more affected than other muscles. And so when we do an examination, we can kind of figure out which muscles are affected and kind of to what degree. The cause of spasticity, the mechanism of it, is actually kind of incompletely understood at this point. We know that, let me see what I have on the next slide. Okay. Yeah, we know that in a normal course of events, you have motor neurons, upper motor neurons, that go from your brain to your spinal cord, and then they connect to the lower motor neurons in your spinal cord, which then transmit the signal to the muscles to make them contract. So that's kind of the normal course of events. And then you also have, so we think of multiple different kind of descending influences coming from the brain to the spinal cord, some of which are inhibitory or kind of telling the muscles to relax. And then you've also kind of got feedback loops coming from the muscles themselves. You have kind of specialized sensors or receptors in the muscles, in the muscle fibers that can make the muscles contract as well. And so in a normal state of things, those two kind of balance each other, but it's thought that spasticity is related to when there's like an injury to that upper motor neuron, which leads to kind of an excess excitability kind of thing, in which the muscle, the lower motor neuron is being told to contract excessively. And there may be different mechanisms depending on the person and depending on where the lesion is in the nervous system. And as I said, we see it in MS, but we can also see it in other conditions: traumatic brain injury or traumatic spine injury, stroke, cerebral palsy, etc. So that's kind of in a nutshell what is spasticity, but what isn't it? Well, here, I've listed a few things that people with MS, some of them can also get, things like weakness. So, and that's where things can get a little tricky, because often somebody who has an upper motor neuron injury or lesion will get weak and become spastic. So you get a little bit of both. Numbness, we think of numbness as more of like affecting sensory pathways. So information coming from the body, from the extremities, back towards the center, back towards the spine and towards the brain. So that those kind of systems, when they're affected by things like MS, that'll lead to numbness, tingling, abnormal sensations, things of that nature. That's a little bit separate from spasticity. Again, people can have both, but that's not exactly what we're talking about here. Rigidity is something that we'll often see get confused, and even among medical professionals, that can be a little tricky. So rigidity is increased tone. So spasticity is increased tone, rigidity is increased tone, but spasticity is, again, this kind of velocity dependent increase in tone. So what do I mean by that? I mean, if I have somebody lying here, like pretend it's an examination table and they're lying flat, if I very slowly manipulate their leg, I might not feel much in the way of an increased tone if they have spasticity. But if I give it like a quick flip, then that's when you can feel like a catch. So that's that kind of velocity dependence that we're talking about. And sometimes we can also see it in a length dependent way. What do I mean by that? So if there's a limb that's really tight from spasticity, initially, if I try to pull on it, there's a lot of resistance. But then after a certain point, there's a give and it becomes very easy to move. We call that kind of a clasp knife situation. So that's another feature that we'll see with spasticity specifically. Rigidity, so a symptom that can be a symptom of other neurological conditions like Parkinson's disease, but there the increased tone is not velocity dependent. It's kind of it doesn't matter how quickly or not quickly you move the limb. There's an increase in tone there and a resistance to movement. And then sometimes people will say, we'll use seizures, or we'll say there's spasticity when really what they're describing is seizures, which some types of seizures can cause an increase in tone, at least temporarily. That's that tonic phase of like a generalized tonic-clonic seizure, which is a grand mal seizure. But that's a kind of a short-lived phenomenon, and that's not really what we're talking about. That has its own treatments, which are slightly different from the treatments we'll use for spasticity, although there is some overlap. There are different ways to grade spasticity. There's no one universally accepted way of doing it. This one on the right here, the modified Ashworth scale, is probably the most commonly used one, and it goes from 0 to 4, and it basically 0 is normal tone, and then 1 you've got like a slight increase in tone, 1 plus, and then 2 it's kind of more moderate increase in tone, to level 3 it's like a pretty significant amount of spasticity, and then 4 it's really the person who's got contracture and like no movement, and you can't get it to fully go through the range of motion. And so that's kind of the most commonly used scale. And then there's also subjective scales, that, we'll see used in studies and things for having the patient grade their own level of spasticity from 0 to 10 or what have you. So things that can make spasticity worse are also things that we see make other symptoms in MS worse. So things like an illness, an infection, sometimes elevated body temperature, either from like a fever related to an illness or from like, exercise or something like that. Increase in kind of external stress or anxiety can worsen spasticity. So all those things we see, worsen all sorts of different MS symptoms. Specifically with spasticity, though, sometimes certain movements or even just like certain postures can lead to increase in spasticity, pain, and not necessarily because that spastic area is painful, but with that can certainly be true. But even if you have like, pain in the low back, that's making your leg spasticity worse. I've seen that before. Even like certain touching, like that can trigger things to be worse with spasticity. Constipation, which is another common MS symptom, we'll also see that as a worsening spasticity. So a lot of things that could potentially worsen spasticity and things that are potentially treatable or avoidable. So let's get into kind of how do we treat spasticity. And I've divided it here into whether the spasticity is mild to moderate or more severe. There is some overlap. So even when it is severe, you might still be doing some of the things that you would do in the mild to moderate category. We have things to do at home, physiotherapy or rehab, oral muscle relaxants or pills. And then when it gets more severe, intrathecal baclofen, Botox injections, and then potentially surgery, including things like rhizotomy. And I'll get into all of these. So things you can do at home. Okay, you see the little icon? AI generated. So these would include, kind of basic things like stretching, heat, ice, all of those things. I mean, sometimes, alternating heat or ice. Some of those things can work well with spasticity, or also, with heat or ice, at least with things like nerve pain. Sometimes if we're going to consider, treating somebody with a medication before we use a prescription kind of muscle relaxant, we might use something like a magnesium supplementation. So those are things that can all easily be done at home and just see, does it have an impact on the spasticity? If the spasticity is happening all the time, then you can kind of pretty quickly see whether it's making a difference or not. If it's happening, irregularly, only at certain times of the day, then it might be a little bit harder to see, but you can still do the experiment at home and see if it makes a difference. So physiotherapy or rehab, I think this is a really important part, and it's something that we'll often recommend in folks who have, weakness or spasticity. But I think with the spasticity, I think it tends to be a little bit more overlooked. If it's weakness or imbalance, then we're like, oh yeah, of course, rehab, that makes sense. But I think with spasticity, especially, we don't do that enough. We don't think about that enough. But they can potentially be important, and they can use different modalities, including things like dry needling, acupuncture, electrical stimulation, or FES. All of those things can potentially be beneficial in working with somebody who knows what they're doing. And then onto the oral anti-spasticity meds or muscle relaxants. As you can see, there's a number of different ones here. We, as neurologists, will commonly prescribe one or another of these when people have spasticity. But, I guess I should, mention at this point that we've kind of been talking about spasticity so far as though it is a bad thing, which it usually is, although to a certain extent, spasticity can be useful or beneficial. What do I mean by that? Well, if somebody has some weakness in a limb, but that limb is also spastic, we'll say the leg, they can be relying on a little bit that spasticity to maintain posture and to be able to bear weight on that limb. If you give something like a muscle relaxant to reduce the amount of spasticity, what you might see is the weakness then it becomes more apparent because you no longer have that stiffness, that kind of crutch-like posture to hold up the leg, and then you can have buckling, right? So it's important to keep that part in mind. So if you are, if there's somebody which again commonly occurs, that there's weakness and spasticity coexisting, but if that amount of weakness, if the spasticity was kind of compensating for the weakness and allowing the person to continue to walk, and then you kind of remove that, then that's when you can potentially see trouble. But again, we'll use all of these different medications to try to treat spasticity, and they work in slightly different mechanisms. So for instance, this first one, baclofen, which is probably our most commonly prescribed one, will use that's acts on a certain receptor, the GABA receptor, the GABA B. You also have things like lower down the diazepam or other benzodiazepines like clonazepam, which I didn't list. That works also on GABA, but a GABA A. Tizanidine here will work on a alpha-2 adrenergic receptor. So different mechanisms there, but kind of the overall goal is the same, which is to kind of loosen the muscle up. And some of these, like dantrolene, we don't use quite as much, at least in this country. And then the ones down at the bottom, pregabalin and gabapentin, I personally use those a lot, but more often for nerve pain than for just spasticity. If there's spasticity and nerve pain, great. Maybe we'll try that, or maybe we'll try that and baclofen. You can use more than one of them simultaneously, but I try not to use like 3 at a time or something like that. And you want to try to get to a decent dose, which depends on which medication we're talking about, what the dose might be. But if you want to get to a point where you've given that particular medication an adequate trial, and it's either not working or the person runs into intolerable side effects before you can really say that, okay, that didn't work. And then if you've done that and done it with a couple of them and it's really not, the spasticity is still there and it's not improving, then that's where you're getting into the more moderate to severe category, and we should be talking about some of these other treatment modalities. This was a Swedish study that was published actually pretty recently that looked at prescriptions for baclofen. Baclofen in Sweden apparently is only indicated for MS, which I didn't know before. And so they looked at MS registries of people who were with incident MS or new MS and prevalent MS or existing MS. And they found more than 1,800 people with MS with new MS and about 3,500 with the existing MS. And of those, about 10% of the new MS patients were prescribed baclofen, and about 19% of the existing MS patients were prescribed baclofen. And what they found when they looked at people over time, and they did this observation for about 10 years, was that in most cases, people stopped taking the baclofen after a certain period of time. So this graph that you're seeing here is looking at it over a 180-day span. So the one on the left is all comers, and then they've broken it down by what type of MS, relapsing, primary progressive, secondary progressive, and then the one on the very right is broken down by EDSS, or how disabled a person was, with the lowest levels of disability at the top. So you can see, even in the people who had higher levels of disability, there was still that same within 180 days, most people seem to stop taking it, but it was less so with people who had higher levels of disability. But I mean, this just kind of speaks to the idea that, our treatments, they're pretty commonly prescribed, but, for some reason or another, a lot of people end up stopping them. So what other options are there? Well, there's baclofen delivered intrathecally through a pump. And so this is something that is done surgically. So you end up having a neurosurgeon who kind of inserts this device. You have like a reservoir, a pump that gets inserted into the abdomen, and then the catheter that goes from that into the spine. So before that happens, first, there's usually a kind of a testing phase where a person will get, well, it's kind of like a spinal tap, but instead of withdrawing fluid, they'll inject some small amount of baclofen to see if it actually does in the intrathecal space, so around in the spinal canal, to see if it actually does that. And the idea here with this is that, when taken orally, baclofen, there's only so much you can take before you start running into, it makes you foggy or sleepy or what have you. And so if you deliver it directly into the spinal canal, then you end up with more bang for your buck and fewer of those kind of cognitive or fatigue-like side effects. And so this can be potentially an option, but basically, once it's in there, you end up coming to see a provider, and then it needs to be programmed, and you can set the rate and how much is given at different times, and depending on the rate and how much quantity is the reservoir can hold, you might need to come back every few weeks to every few months to get it refilled. So it is a good option for some people, although you kind of have to be willing and able to come back in and have it reprogrammed. There are also now companies that can come to your home and do it too, so that might be an advantage there. Well, some of the disadvantages, well, you can get infections, you can get leakage either there, or the catheter can leak, or it can get kinked. Eventually the pump will run out, the battery will die, and then it might need to be replaced. That's usually after several years. So there are potential issues that you would want to go through, with your provider to make sure that it was in your best interest, basically. Here's another modality that sometimes we'll use for folks with more moderate to severe spasticity: Botox injections. This is, I'm sure many of you are familiar with Botox, but it actually is a toxin, botulinum toxin, which comes originally from a bacteria, and it's basically a paralytic agent. So it prevents the neuron from actually firing. And so we can use it in people who have spasticity, depending on where they have it. And some of these are pictures where some that are common places for people to have spasticity and MS. You inject it into the muscle, and then usually after a few months, it kind of wears off, or potentially it's because there's new sprouting of neurons or something like that. So then you end up needing to redo it again. So it's another thing that not as often usually as the baclofen pump, but you do need to kind of keep going back to maintain the benefits of this treatment. And it's a paralytic agent, so it does, even kind of like that dynamic we were talking about before. It can cause weakness, and if to the extent that you still need to use that arm, or you still need to use that leg, it's gonna make it weaker. So it's typically only used in for people where it's really, you're not getting a lot of function out of that limb at all, and it's really just very spastic and immobile. And so then if you loosen things up a little bit, then that'll allow for greater kind of range of motion, and then that can make things easier, not just for the patient, but also for the caregiver, for things like transfers, or for getting clothes on, or undressing, things like that. And so this can potentially be a useful addition. And I'll briefly mention this spasticity treated by nabiximols, because of course can't have a talk in Colorado without talking about marijuana in some way. So nabiximols, or branded Sativex, is an oral mucosal spray containing an equal combination of CBD, which is a component of marijuana, and the delta-9 THC. It is licensed in Europe, Canada, and other places around the world, but not in the US. But I mean, to a certain extent, we could probably extrapolate it to, from things that are available here. And in fact, we have, at least from, anecdotal experience and from, surveys that we've done, found that, our patients do use like marijuana derivatives to treat their spasticity, especially, things like spasticity, nerve pain tend to be the things that best respond, at least according to what you're telling us, to these types of things. And in this kind of long-term study, they looked at folks who were treated with Sativex, or this mix of CBD and THC, and they found that about half experienced an initial treatment response, with about a third who had this kind of more durable improvement in their spasticity beyond 4 weeks, with side effects including potential drowsiness and vertigo. Briefly mentioned transcranial magnetic stimulation. This is an experimental approach to improve pain or spasticity in MS. There have not been large, multi-center studies on this topic, like you've seen in some of like the randomized control trials for MS disease modifying therapies. But essentially the idea is you have this device, you place it over the desired, the targeted area of your brain, say the primary motor cortex, and then it's usually given like in a repetitive magnetic pulse. There have been some small studies that have suggested some benefit on spasticity that have lasted, at least a couple weeks. But I think this is something where we need to figure out, like, does it work in a lot of people, and like how often, what's the right parameters, how often do you need to give it, all that stuff. And so I'm interested in this, so stay tuned. But we'll need to see more research on it. And then a couple more, just so rhizotomy or other interventions. So dorsal rhizotomy is basically where a surgeon goes in and selectively cuts a dorsal spinal nerve to prevent transmission. So this is part of that feedback loop that I was talking about, where the muscles talk to the spinal neuron and then try to and make it more excitatory. So this is kind of preventing that excitatory input and hopefully kind of alleviating the spasticity. And then there are other surgical approaches that are, not used quite as much, things like, just completely getting rid of the nerves involved, but which of course could potentially have side effects, as you can imagine. And then there are things that are more kind of working on not the nerves themselves, but like the tendons or the orthopedic issues that can result from like prolonged severe spasticity, where people can get like abnormal curvatures of their spine or the contractures, and there they can like lengthen tendons. They can do tendon releases or transfers. So that, yeah, again, that's kind of more reserved for folks who have really more of the severe complications from it. And then I think this is my last data slide. So spinal cord stimulator will often consider in folks who have intractable nerve pain, or can also be used for spasticity, although I think we still need to figure out exactly how good it is. There was a systematic review that found some benefit in reducing MS-related spasticity, but it was kind of was variable degrees. So figuring out like kind of what's the right level that it would need to go at and the optimal amount of stimulation. And here you would be working with a neurologist, probably a physiatrist, a rehab person, a pain specialist potentially, and a surgeon. So there'd be a lot of people involved in that kind of decision. So to conclude, spasticity, it's a very common symptom in MS, and I think maybe under-recognized. So it is important, if you think you might have it, to bring it up with your neurologist, because treatments can potentially improve your quality of life, with the caveat that our medicines generally have a kind of a modest effect and are more useful in kind of the more mild to moderate cases. The oral medicines, whereas there are some options for people who are both more moderate to severe spasticity, including intrathecal baclofen and Botox. But admittedly, we do need more and better treatments for this. These are my references, and thank you for your attention.